very much for the kind introduction. Thank you for spilling my secrets here, Laurie. It's my great pleasure to continue in the spirit of this meeting, which I really feel is great that we all are here to look over the rim of our teacups and learn from each other and see where we can improve things. And I want to kind of take Laurie's further from her experience to the further clinical experience, talk a little bit about the immunological backgrounds, discoveries, and boundaries, and then could we do this actually up into adulthood? Let's start with the clinical experience. We've already seen Karl Landsteiner. In 1990, David Cooper summarized the experience with heart transplants at the time of ABO incompatibles and in adults, and found that 2/3 of them had a degree of rejection that barely let them out of the operation room. And so when Laurie caught her big fish, 1995, thinking about ABO incompatible transplant, not everybody was enthusiastic about the idea. However, we should also keep in mind that we've learned a lot already. So this is, we've seen baby Faye earlier today. This is also from Loma Linda, baby Moses the year after, and he's almost 40 years old now, not as cute anymore maybe, but still kicking with his first heart transplant and currently the oldest surviving baby transplant. And as you can see here, the babies in purple have a different survival perspective. So even going back 25 years, more than half of them are still alive with their first heart transplant. And if you take out of the equation the high mortality early on because they're so sick, then you see that they actually have a very good life expectancy or survival expectancy, much better than anybody later in life. Unfortunately, they are also the group that needs heart transplant in childhood the most, and the one that has the highest risk of not surviving to transplantation. This is US data that is a while old, at which time of the less than 5 kilo old babies, about 25% would die waiting for a transplant. And sadly, in last year's UNOS report, it's still 29%. In the US, that has an excellent allocation system and good demographics, slightly different from what we're facing, where we have 15 million people on 4.5 million square kilometers in Western Canada, and our furthest patient being as far away as Mexico or Cuba. And so if you think about the population density in this population, it's not a surprise that in the 90s, when Laurie started her idea, the waitlist mortality was around 50% in Canada. However, she already showed us the survival at 1 and 5 years in the first small study group was 80%, similar to what you would expect with compatible transplants. The waitlist mortality was reduced from 58 to about 13%. So some people in the world started following. This is not an oversized toaster, but it's actually the University of Munich, Ludwig Maximilians University in Germany, who did the second 2 cases where I got in touch with this topic. The UK followed with 21 cases already pushing the age limits a bit to 30 months of age. And then the first kind of group study from the Pediatric Heart Transplant Society included 90 patients showing similar 1-year survival and freedom from rejection. But interestingly, not surprisingly though, that the ABO incompatible recipients were sicker children. So people would reserve it for their sickest patients, just being worried about this new thing and potential intrinsic dangers. But if we look further on, then you see from these first few cases, this is 1999, so still kind of a niche thing. It has evolved into more and more of a standard therapy for less than 2-year-old patients. So about 40% of the patients in 2018 in North America and Europe did get an ABO incompatible transplant, and up to 80% were listed for ABO incompatible. Still, in these days, it were younger patients. They were more likely to have congenital heart disease, more likely to be on ventilator, ECMO or ventricular assist devices. They had a higher urgency listing. More of them were blood group O, so still sicker patients that would get it. And there was a significant benefit, particularly for the blood group O patients, to get a heart faster than if they were not listed ABO incompatibly. And keep in mind that both of these curves improve because the more incompatible organs you allocate, the more compatible you also have available. So both of those groups move better, making us probably underestimate the benefit of this technique. This growing experience also allowed us to do kind of more meaningful comparisons. And in 2020, we put together data from 364 ABO incompatible patients and compared them with 1,842 ABO compatible recipients. There were also 27 children in this cohort that were older than 2 years, so they're not in the main cohort, but we analyzed their survival isolated. I already mentioned the higher risk profile, but having so many patients, we were able to match each of the 364 ABO incompatible patients to 2 patients that were similar in demographics in terms of congenital heart disease versus cardiomyopathy, being on mechanical cardiac support, and also when they were transplanted more recently or earlier. And this is the key outcomes. So survival up to 10 years here, similar compared with the whole cohort, with the matched cohort. Freedom from graft vasculopathy, which is chronic rejection in heart transplantation, similar. Freedom from tumors, similar. Earlier studies have suggested that the risk of rejection may actually even be lower in incompatibles than compatibles. And that was true, again, when we compared it with the whole cohort, but not when we compared it with the matched patients, which suggests that even within those less than 2-year-olds, it was probably the younger kids, and it was the kids that had their transplant more recently where they were associated with less rejection. Laurie just showed us this data, which was already in the first publication, which in contrast to the other children who would just come up normally with their antibodies against their non-self blood group, the ABO incompatible recipients showed a suppressed response towards their antibodies of their donor. And that showed to be true up to 10 years out. Here in this study, you can see all recipients of the A heart developing normal green anti-B antibodies and having suppressed anti-A antibody response. And the same the other way around, B into O, you get a normal development of anti-A antibodies, but suppressed anti-B, all within the limitations of the techniques. The really interesting thing, though, was that we found surprisingly that these kids also had fewer antibodies against class 2 HLA, and none of them had donor-specific antibodies. And a similar study was done in Seattle later on that found the same thing. So other than what you would think, oh, we have another foreign thing here, so they should actually respond stronger, they respond less. This is a really surprising finding, and that's why it's important to look into the immunological background. So probably all of you know this kind of classic immune response model where an antigen-presenting cell deals with a protein or peptide by processing it, presenting it in the MHC2 complex, and then the CD4 cell activating these macrophages or other antigen-presenting cells inside the toxic T cells for immune response, or activating antibody-producing cells like B cells that have bound the same antigen to produce antibodies, thereby becoming a plasma cell, but also form memory and proliferate. And this actually works as soon as we're born. So this is nice data looking into newborns that had their hearts reconstructed or their vessels reconstructed with human vascular tissue in the first week of life. And you can see if they received these homografts or allografts, 80% of them were sensitized by 1 year as compared to the ones that didn't get human tissue for reconstruction that did not respond to HLA. Laurie has shown us much more eloquent that these are polysaccharides for A and B, which is different from HLA, which are proteins. So a lot of the things may not apply to the same point, but usually we develop antibodies against them, and we don't need to be exposed to blood or human tissue to do so. But we also know from infectious diseases that infants and young children have a natural gap in response to sugar. So in sugar encapsulated or polysaccharide encapsulated bacteria cause a lot of trouble in early childhood. This is something that I grew up with, epiglottitis, a pussy infection of the throat that led to the death of many children up to the mid-80s. Pneumococcal infections, meningococcal infections, all very feared amongst pediatricians. And the key difference here is that these polysaccharides, these sugars, do not fit into the MHC2 complex, so they cannot follow this process I just showed through the antigen-presenting cells. Instead, they can activate B cells by just linking them together if it's a long chain, and then many of those B cells are sitting on there. They will cross-activate each other and produce antibodies. They're polyclonal because they're not kind of as specific, and there's many of them, and it's disputed whether there is memory development from that. But also on the single cell level, the immune system works actually together with the innate immune system. So complement binds to those polysaccharides, and complement has a receptor on the B cell called the B cell co-receptor. And if that gets activated even without a T cell signal, these cells become activated as well. Now, even in the 1980s, people had already noticed that the cells that respond to polysaccharides are sitting in the splenic marginal zones, and it's not really built until 6, 12, 18 months of age. And similar to that, we found in our patient, they are lacking these CD19, CD21 high cells in the first year. If we go beyond that, B-cell memory is next step to then being able to respond again to these invading antigens. And that's reflected in CD27. And as you can see here, it takes about 5 years to reach adult values, particularly for the IgM expressing memory B cells, which we're able to show are the key cells to respond to blood group antigens. And if we just compare young children, less than 2-year-olds, with adults, you see that there's significant deficit in those cells. And that's probably what facilitates ABO-incompatible transplantation in the first spot. Now, interestingly, once you have an ABO-incompatible heart, your immune system develops differently. And these patients with ABO-incompatibles had a persistent suppression of these IgM-expressing memory B cells and instead developed more of the switched memory B cells. That makes you worried and think, oh, so now we've kind of affected their ability to respond to polysaccharides, and is that going to put them at risk for infections? Which brings me to, again, back to the vaccine story and to one of, I still think, the greatest successes of applied immunology, which is conjugate vaccines. So this deficiency in responding to sugars was overcome by binding your sugars to a protein. So the antigen-presenting cell presents the protein to a T cell, and the T cell also activates the B cell that have bound the polysaccharides. And if you look at it, many of you don't even know this disease epiglottitis anymore, because when they tried pure polysaccharides, nothing happened. But once they were able to conjugate those, the infants now all developed immunity against Haemophilus influenza type B, and that disease has pretty much disappeared worldwide. Now, what's so exciting about that in transplant? Why are we even talking about this? Because now we see the opposite possibility, that the B cell that is activated or not activated against the polysaccharide seems to also affect what the T cells do with the remaining antigens. And how could you imagine that? This is a dumbed down for a cardiologist mind kind of model. So usually you'll have APCs, antigen-presenting cells, you'll have T cells, you'll have B cells, they produce antibodies against HLA, they destroy your graft. Very clear. If we now have these A and B cells, and they are exposed at a time where they don't get T cell help, so they become anergic, they actually seem to affect what happens downstream with B cells against HLA and not generate these. I mentioned that we were worried. Now, are they deficient against infections? Do they all get encapsulated bacteria infections? Interestingly, we found the opposite was the case. So even in the matched cohort, there's no higher frequency of infections in general, and no higher frequency of infections with encapsulated bacteria. So no additional risk from the immunological changes that come with ABO-incompatible transplantation. So can we do it into adulthood? So in contrast to Laurie's picture with like the 1 year, I don't think anybody debates about 1 year or 2 years anymore. So these guys probably are all pretty safe. But what about these guys? Could we maybe do it for them as well? And currently, kind of the world experience in Edmonton, we went up to 6 years of age. A really interesting case is this one. She was a girl that was HLA sensitized. So we started depleting her B cells and treating her for HLA. And with that, her anti-A antibodies came down to the point that we got a really good offer from an HLA match, but ABO incompatible, but said, well, she's nice and low, let's give it a shot. And this is what happened, 4 years freedom of any antibodies. So that's worked just fine. In the UK, they have gone up to 9 years now with low titers and up to 8 years with high titers. And I'll talk about immunosuppression in just a second. The other thing that we've learned is if you have then a 15, 18, whatever, 20-year-old who needs a retransplantation, it seems to be safe to use the same incompatible organ again, opening up the spectrum for them. Now, what about the older children? In the PHTS study, same survival as the ones that were compatibly transplanted. In Sweden, they did 2 selected adult patients that were already low antibodies to begin and desensitized them, and they did fine. This is an interesting paper where in 2016, a group went and analyzed, or 2015, the data from the ISHLT, and amongst 75,000 patients, there were 94 that accidentally got an ABO incompatible heart. And as you see, the early mortality is high, but then it kind of flattens. And if you take the 1 year mortality out, or if you look just at the patients that had this happen in the last 10 years, there's actually no difference in survival, suggesting that if you would have treated them the right way, maybe there wouldn't have been that much of a difference. Nori mentioned the kidney transplant experience that goes back a much longer way and has the advantage that if it fails, you can go back to dialysis and your patient doesn't die. And there has been a nice meta-analysis for these studies included, which were only those that had control groups. None of them is a randomized controlled trials. They all had either historic or other kind of variable control groups. And it did suggest that it is a higher mortality at 1 and 3 years, interestingly not at 5 or 8 years. The thing to keep in mind here is you see some of the studies actually show a benefit, other studies show a higher risk. So it's very variable. And from that perspective, the conclusions are questionable. And there's also patient selection bias because same story, people would try to cross a barrier in a desperate patient more likely than in somebody who's stable. That policies make a difference was impressively shown in this study where we looked at the data from UNOS, who changed 2016 their allocation protocol. Before that, they would only allocate ABO incompatible heart if no compatible recipient was there. 2016, they opened it up, also opened up age and other limits. And as you see, while overall there was a continuous trend of just listing more patients, the frequency of transplanting them actually ABO incompatibly changed dramatic in 2016. And with that, the survival of the incompatible recipients improved dramatically so that now in the US, it's the same outcomes as well, while before it was different. Now, interestingly, it's still higher risk profiles for the ABO incompatible listing, but it's switched from reserving it for the 20% sickest to reserving ABO compatible to the 20% healthiest. So it's a bit of a different approach these days. Could we get adults to the same spot? This is experimental data from islet transplantation where they block B cells in their maturation, and they find similar to what has been observed in tolerant, long-term tolerant kidney transplant patients, that presence of transitional B cells that are not fully matured seems to promote tolerance of organs. So could we maybe get adults into the same spot? Simply depleting their B cells is probably not going to get us there because we still have lymph nodes and the spleen and all these things that are different than in the baby, but maybe combining it with some medications to slow down their maturation could work. Along those lines, there's has been a positive trial that has been mentioned a few times. Some of the stuff has been analyzed. Some of them has sadly been taken a very long time to get analyzed in more detail. And we'll have Angela presenting tomorrow some of the data here comparing liver, kidney, and heart patients on how their immune system maturates before and after transplantation. I mentioned this, and this is just a very brief slide about the practicalities. If you move into older patients, you need a lot of blood group O red blood cells and a lot of AB plasma, and the blood bank blocks you from their cell phones if you keep doing that. And therefore, this is a nice technical alternative where you can just put a column into your bypass and therefore don't need any blood products really, but it removes the antibodies as the surgery happens. I'm not going to get into this because I think Anne is going to get into that, and Lori already showed us that not all antibodies are the same, and many of the things are not relevant for much. I have the same picture as Lori has, 1901, Karl Landsteiner's arrangement, 2024, our modern arrangement, so definitely room for improvement there. And Anne's going to tell us about this. And in regards to the question if it's worth doing, I want to show Britain, cardiac surgery, transplantation,